Late nights, skipping the cleanse routine, going to bed with your makeup on. We can put our skin through a lot over the years. Thankfully, Cotia has combined Deer Milk with powerful actives to create skincare that genuinely keeps up with your lifestyle. And thousands of Aussie women are already obsessed. Keen to see what all the fuss is about? Use code MAMAMIA20 for 20% off your order. Cotia, because your skin deserves something extraordinary.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got a Q&A, some written, some speak pipes.
Okay.
Yeah, all very exciting.
Good.
And so we're going to get straight into it because we've already established we don't like the chit-chat.
I like it when people contact us on SpeakPipe.
Yes, absolutely. So if people don't know what we're talking about when we say SpeakPipe, it's we'll put the link in the bottom of the podcast episode. Just click on that. It'll go straight to a website. You don't have to sign up to anything. You just record your message. Then you get an option to either keep or redo. I'm sure people get really sort of
don't overthink it.
Don't overthink it. But
and then it just means that when your question gets answered, we've got your actual voice.
Yeah, which sounds really great.
Yeah.
Good. All right. Well, I'm going to start with this one first.
Hi, my name is Amy. I'm 33 weeks pregnant with my second baby. I was diagnosed with Graves' disease 10 months postpartum with my first, and I've had a total thyroidectomy. My thyroid levels throughout this pregnancy have just been all over the place. My last TSH was 34. I've just been doing a bit of research about it, and I'm concerned about the health implications for not only myself but my baby, in particular their brain function. None of the specialists involved have advised to deliver early or any complications for the baby. I'm just wondering how concerned I should be about my high TSH and any implications that it has for the baby.
This is amazing. Like, I didn't know Graves' disease was even a thing until we got asked a question about Graves' disease in our last Q&A.
Right.
And here's another person asking about Graves' disease.
Yeah, so Graves' disease is a very common form of thyroid dysfunction, more common in women, affects plenty of young women, and is active around the pregnancy years. So thank you for getting in touch with your situation. I'm imagining that the Graves' disease must have been reasonably severe for your carers to have contemplated a total thyroidectomy, because that's a surgical removal of the thyroid gland, and it's not commonly necessary to control thyroid disease. I'm sure it can be, but when the thyroid is completely removed, then the whole point of doing that is that you can then, on a clean slate, just put the thyroid hormone back in and create a much more stable and predictable thyroid environment than your dysfunctional gland could manage. And so it's interesting and a problem that the thyroid control has been poor despite that. I don't want to say I don't know the answer, but the actual day-to-day management of that is outside my area of expertise, and that's why we use endocrinologists, thyroid experts to help us manage this. We definitely, in a situation like this, need to not just be under the care of the obstetric team, but also a care of a physician unit who can manage thyroid disease and try and get this as stable as possible. It is important for the growing health of the baby that the thyroid is stable. But it's also important for the newborn that the baby's thyroid condition is maximised, particularly if there's been transplacental crossing of thyroid autoantibodies. So paediatricians get involved as well. And just recently I saw, in Australia, and I'm sure in most developed countries, they have a test where the baby gets a heel prick after the birth. And one of the things that's tested for on that heel prick is congenital hypothyroidism. So if the baby's got basically no thyroid function, it'll be picked up on that heel prick. And for the first time in my entire career, just recently, somebody's baby was heel prick positive for absent thyroid hormone. And when they imaged the baby's neck, there was no thyroid gland at all.
Whoa.
So that baby went straight onto thyroid supplementation. And that's what that whole heel prick thing is for. So we take this seriously. I'm sure that the situation is able to be corrected, but it does need expert management.
Can I just ask, in your anatomical scan at week 20, would it pick up things like thyroid?
Well, not really. So that they can look at the anatomy of the baby's neck, but it's a bit hard to see. The ultrasound, it's a little bit imprecise for that issue, and because of that, they had to use the heel prick system because we weren't picking these up. Yeah.
Well, I'm going to move on to one of our written questions. It comes from Michelle. Hello, wonderful humans. What you do for the wider community and world will always be appreciated. With a love heart.
Pleasure.
I've listened to every single podcast episode in 1 year and wait until Tuesdays for the next one. I've also completed the Grow My Baby program, both pre-conception and pregnancy. I'm currently completing the program a second time as I'm currently 10 weeks pregnant. My question is, my GP placed me on Metformin back in February 2025 due to my PCOS diagnosis, mild insulin resistance. I was told to keep taking the medication until the end of my first trimester and when the placenta can take over. I'm an average weight. I worry that if I stop taking it, a problem might occur, such as miscarriage. Do I stop taking metformin after 13 weeks or continue? For context, I am 32 years old. Thank you.
Well, thanks for getting in touch. This is an interesting situation because there's actually mixed evidence that continuing the metformin into the pregnancy, whether it's necessary at all, won't harm you. That one of the problems with taking medication in pregnancy, if you've been advised to take it, is that then people get nervous about stopping it. Right? So there's absolutely no need to be concerned about that. It's not going to you're not going to have a miscarriage if you stop the medication. The question is, do you really need it? So one of the things we use metformin for is for things like insulin resistance, where there's some borderline concerning sugars, but don't rise to the level of fully diagnosed diabetes. So what I would do in this situation is whether I continued the metformin or not, I would consider this to be somebody who'd be worthwhile doing a formal fasting oral glucose tolerance test twice, at the start and at 28 weeks. Yeah.
Which is kind of in line with the updated diabetes guidelines that we went through in a previous episode.
Yeah. If you're at high risk, it's different. I think we have to remember that the standard drink the drink and do the test at 28 weeks. That's for normal. That's for low risk. That's for a screen. But if somebody is at high risk, then it's different.
All right, Michelle, I hope that helps you, and thank you so much for joining us along the ride twice.
Yeah, amazing.
Yeah, amazing.
Hit that arvo slump and fighting to refocus? Everything feels harder than it should. I'm Claire Murphy, and this is Well, your weekly wellness reset. No fluff, no fads, no woo-woo, just clear, expert advice to help you bounce back to your best. So whenever you need a second of self-care, join me and our resident GP, Dr. Mariam, for real talk on our bodies, minds, and how to live a healthier life. Listen now, wherever you get your podcasts.
All right, Pat, let's move on to maybe a speak pipe now.
Hi, Dr. Pat and Brigid. At 8 weeks pregnant, I had a bleed, which was the result of a subchorionic haematoma. On the ultrasound report of findings, it was measured at 4.2 mils. My question is, what is the likelihood of reoccurring bleeding, and what does a subchorionic hematoma mean for the rest of my pregnancy? I'm also a lover of all things physical activity and exercise. So I'm just wondering, is this something that is going to impact my ability to continue exercising throughout the rest of my pregnancy? As in my first pregnancy, I was able to exercise quite intensely all the way up until the day I delivered. Thank you. I'd love to hear your thoughts and advice on this.
Now, we've actually got two questions about subchorionic hematoma.
Two in the same? Wow, okay. Yeah, right. So subchorionic hematomas are little blood clots that form near the developing pregnancy, just under the pregnancy sac in the first trimester of pregnancy. And they're really common, and they mostly do nothing bad. The whole system is basically made up of blood vessels. That's what the placenta's for, isn't it? If you've just had a baby and you have a look at the placenta, it's just all made up of great big blood vessels. And at the early stage of pregnancy, it's a miracle they don't all bleed. It's made up of tons of rapidly growing and multiplying blood vessels. And sometimes they will bleed after a minor trauma after intercourse, or all by themselves. And then we go and do an ultrasound and they say, yep, pregnancy looks good. The little fetal pole, the developing fetus, is the right length. There's a heartbeat, but there's a clot next to the sac called a subchorionic hematoma. And then basically it's roughly true that if the development of that hematoma wasn't big enough or severe enough to end the pregnancy then and there, then it probably won't. And it'll sit there and dissolve over the coming weeks. And if you have a look 2 or 3 weeks later on another ultrasound, not that you need to, but you can, it'll typically be gone. They are associated with miscarriage, but if you have not miscarried, but they notice that the subchorionic hematoma is there, then it wasn't bad enough to cause the miscarriage in the first place, and it probably won't. Yeah.
Do you think, we're using ultrasound more? I mean, this is not a new thing, subchorionic hematomas, but perhaps people weren't told that by their sonographer previously.
Absolutely. So they're an ultrasound finding that we tell people about because they're there. But what people really need to know is, have I miscarried or not? And we're talking about a very small thing, so that I will sometimes say to people, intercourse in early pregnancy does not cause a miscarriage. But if you've got a blood clot sitting there and you have plenty of intercourse, it might shake some more blood loose, which is going to frighten you, take all the fun out of it, and you may not want to do that until things have settled down for a couple of weeks, like no bleeding for a couple of weeks in a row and then try again. There's no reason why someone shouldn't be exercising if they've previously been diagnosed with a subchorionic hematoma, except if that exercise is making them bleed. Because, again, it may not change the outcome, but it'll upset you. So if you're not bleeding and you haven't been bleeding, then carry on as per normal.
Great. All right, well, let's listen to the other one about subchorionic hematoma. I just like probably saying it by now. Here we go.
Hi, my name's Alex. I love your podcast. I'm currently 15 weeks pregnant. This is my second pregnancy and the first one. I went in for my 9-week scan thinking everything was all good because I'd seen the heartbeat twice, and it turns out that the baby had died 2 weeks before. It was very traumatic. I'm still not over it. It's made me a completely different person. It's changed me forever. I had to get surgery, which I didn't expect, and it feels like no one around me has been through this. People didn't really understand. They just said things that were hurtful and told me to get over it. I just wondered, how common is a missed miscarriage? Also, in both pregnancies, I had a subchorionic hematoma, and that ended up I had lots of bleeding and had to go to ED a few times thinking I was miscarrying for both pregnancies. In the first one, it got bigger when the baby had died, and so I kind of worry that it killed the baby. There's really not much info online. It's more common in IVF pregnancies, older women with lots of children. I don't meet any of that. And so I just wondered how common is the subchorionic hematoma? Do you know anything about it?
Sure. I'm so sorry to hear that.
Yeah, what a horrible story.
Pregnancy loss. That's terrible. We're sorry to hear about your loss and your pain. This is an example of somebody whose subchorionic hematoma was clinically significant. Yeah. Now, we'll never know whether that was the exact cause of the miscarriage, or it might have been a genetically abnormal baby or a chromosomal baby or something like that. But the presence of the little blood clot on the early ultrasound may or may not have caused the miscarriage. Unfortunately, we'll never know that. Plenty of people have got subchorionic hematomas seen as an incidental finding on ultrasound. They've never bled. They don't miscarry, and the pregnancy is perfectly normal. They can't be treated, anyway. And so the relevance to this person, the actual relevance to the outcome is not something that we can really determine.
I just want to pick up on her saying that she felt like no one around her.
Yeah, that's the problematic
That is
bit.
the problem. Yeah.
Okay,
You're not alone.
Yeah, you're not alone. Pregnancy loss is a near universal human experience for women, unfortunately. And when I say that, not everybody's had a miscarriage, but not everybody knows they've had a miscarriage. But the studies show that if you're a sexually active a woman trying for a pregnancy and not on any contraception, small conceptions of very early pregnancies happen much more often than the woman is strictly aware of. And what appears to be a period that came a couple of days later and was unusually heavy can be an early pregnancy loss.
And those monitoring and doing all the tests and everything kind of clock those.
If you're in a study and you're being monitored, they would know. Yeah, so that you would be giving them a urine specimen every week, and they would know if a pregnancy had come and gone, but you may not know. So those studies have been done and have proven that these little pregnancies come and go a fair bit in couples trying for a pregnancy, but are not always identified as a pregnancy. What I'm saying is that you're not alone. This is a challenge for society to deal with better, because unfortunately early pregnancy loss is a fact of reproductive life. I'm sorry to hear that at this stage it feels like you'll never be the same. If it's of any consolation, my experience is my experience looking after hundreds of women in your circumstance is that it gets a lot better. Yeah, so people's resilience continues to amaze me even this late in my career. And what appears to be a profoundly upsetting and traumatic event at the time, it's remarkable how well that's integrated into a woman's general experience of life as time goes by, and how little it is associated with significant maladaptation or the development of a mental illness or anything, of depression or anything like that. It's amazing how resilient people can be. Now, that's not to say you'll forget about it. In fact, I've looked after women in their 90s who have told me about their pregnancy losses. It's not that they've forgotten about it for one moment. It's just that it stopped hurting a long time ago. Yeah, you should be hopeful that it will not hurt this much forever. Okay. How can we do this better? One of the things that we've covered in our podcast in the past is like a cheat sheet for the people around you on how to speak to people who've had a pregnancy loss. And to be honest, it's not that hard, but like all of the things that we find difficult to talk about, it feels hard.
Yeah.
Yeah, it feels hard. So if somebody that you know has had a pregnancy loss, the worst thing you can do is not contact them at all, in my opinion. That would be interpreted by that person as deeply unkind. And the second worst thing would be to say something. It would be to contact the person, but say something clearly inappropriate. And if you're going through the pain, things that trivialise the pain are not at all helpful. Yeah.
I think that is the reason why people don't contact people in the first place, because they're scared about saying the wrong
So
thing.
what we need is a new language around this. And we as a society have done reasonably well with new languages. knowing somebody who was gay in mainstream society used to be a deeply problematic and shameful thing, and now it's not. You know what I mean?
Yeah,
That we have evolved, not only in our attitudes to things, but our language, and this one shouldn't be this hard. Yeah.
Yeah, so I think Pat's referring to episode 27. I know that because I think in a previous episode we were talking about it because of this very thing. What are some of the easy sentences that you can have in your brain that you can just recall if you're in that situation where someone's just told you that they've had a miscarriage, just so you know straight away, like this is an appropriate thing to say, this will help that person, instead of going, oh my God, I don't know what I'm going to say, and whatever I say is going to be wrong, so I'm just not going to say anything at all.
Yeah, which is which helps you but doesn't help them.
No, that's right.
Yeah. Acknowledging the person's loss and acknowledging the person's pain can be as simple as saying, I am sorry to hear about the pain you're going through, and I'm sorry for your loss.
Good luck. I hope that has helped. Go back and have a listen to episode 27, and I think we've got another one on miscarriage too, but we'll put that in our show notes because I think the title is something like A Common Pain We All Share in Silence. And if anything happens with this podcast, I hope it is that we get better at supporting people that have had a miscarriage.
Yes.
And it's no longer silence.
Yes.
All right, I'm going to read the next one. Hi there. I'm trying to learn more about medications/medical care to prepare for this appointment at week 21 that I have with a doctor in the public system. I choose to refuse transfusions of blood.
Struggling with the anxiety that comes with adulting?
Or maybe you've suddenly become the parent to your parents.
Wondering if you might have ADHD, but unsure if or how to get a diagnosis?
I'm clinical psychologist Dr. Anastasia Horonis.
And I'm Ashani Dante. We're your hosts of But Are You Happy?
Bringing you all the self-development and mental health information you actually need.
New episodes drop every Saturday morning.
Just in time for your hot girl walk.
So tune in to But Are You Happy? The podcast where overthinking finally gets the spotlight it deserves. Made in partnership with Medibank.
And blood fractions. So we are putting together a plan earlier to more cautiously stop/reduce bleeding earlier in all possible scenarios: vaginal birth, assisted birth, caesarean section, ICU care, as well as in the care for my baby upon delivery, such as delayed cord clamping, vitamin K injection. As a participant in the Grow My Baby program and avid listener of The Kick, I would love to hear your opinion of what to consider in these scenarios based on your experience. Otherwise, I'm generally healthy, considered low risk. I work as a researcher and allied health professional, but would like the opinion of an experienced specialist obstetrician, as I anticipate I may see a junior doctor in the public hospital system for this appointment. We had not planned this pregnancy, so going public was what was recommended by my GP.
Great.
There's so much there.
That is so great. Yeah. Good. A couple of things stand out for me with this. One is that helping you make this plan within the public system is not a job for a junior doctor when you go in to be seen. You might see the world's best junior doctor, but that's not the point. This is a job for an experienced clinician who knows tons about this situation. Okay, so you don't have to see the boss of the department every time you go in, but you should be seeing a senior specialist at least once or twice or three times in your pregnancy care to make sure that a plan for this situation is locked down. All right, and that's not a job for junior people. A junior person could sit in and learn tons, but that's not a situation where a junior person would help you make the decisions. In my experience, people who are refusing blood or blood products, it's typically for religious reasons, and it's not for safety reasons. In Australia, donated blood is extremely safe. There's been some issues in the distant past, but these days everything's triple and quadruple tested for infections. So we're typically talking about a group who resist a blood transfusion for religious reasons. Needing a blood transfusion as a result of a pregnancy outcome is an unusual thing to happen, a very unusual thing to happen, but by no means an impossible thing to happen. So we need a plan. The best thing that can be done for the planning is that bleeding's better prevented than treated. what we tend to do on the labour ward in the hospital, if we've got no patients, if no one's coming in labour that day, doesn't happen very often, but if it does, then we don't waste our time. We sit around running drills. We'll say, the senior people say to the junior people, rightio, Mrs. Bloggs comes in and the baby's come out, and then she just starts, hosing out blood in a major postpartum hemorrhage. What are you going to do? And we train for it so that on the day it happens, the responses are automatic and immediate. And whilst most people are at what we call standard risk of a hemorrhage, if we've got a patient who's at high risk of a hemorrhage, for example, they've had a really bad postpartum hemorrhage before, or they have a known blood clotting problem, or they are seriously obese, or a number of the conditions that are known to predispose to postpartum hemorrhage, twins, placenta previa, then we don't just sit there running drills. We actually treat that person preventatively and a little more aggressively because we know their hemorrhage is much better prevented than treated. Yeah. And if there's somebody who's refusing blood, then my approach to that is usually to say, rightio, let's never get to the blood part of the algorithm. Right? Let's stop bleeding in its tracks long before we get down to give transfusion, which is at the bottom. Yeah. And so what I might recommend to somebody who was refusing blood is let's be more aggressive at the top of the flowchart. And, for example, make sure that there's a short interval between the baby being out and the placenta being out. Let's do things like rubbing the fundus, rubbing the top of the uterus to help it contract, to rapidly expel the placenta, which we might not do at all in a low-risk situation, but we might do as a simple intervention in a high-risk situation to make sure we never get to the bottom of the flowchart, and then give some preventative medications to help the placenta be expelled more quickly and prevent postpartum hemorrhage. And then sometimes give medications, non-blood things, that can be given preventatively, like misoprostol tablets that you put in your bottom after the baby comes out to help uterus stay well contracted. And the whole idea is to do a lot of things at the top of the page that are highly acceptable to the patient so that you never get to the bottom of the page.
How easy or difficult is it? And I like how she already knows that there's a high possibility that if you didn't have an issue, you would see a junior doctor in a public system.
Yep.
So she knows that already. But how difficult is it for somebody to say, look, I would like to see the senior consultant?
In a well-functioning unit, the patient shouldn't have to bring that to your attention. Okay.
Yes.
The whole point of booking in and not just turning up in labour, the whole point of booking into a health service for the management of the antepartum care, during the pregnancy care, is that so that somebody senior with some obstetric experience can have a look at the situation and ask the right questions and help that patient make a plan for their care for the remainder of the pregnancy. And if you don't know what you don't know, then you don't ask the right questions and the right plan doesn't get made. But that's why we want people to see a senior person at least once. Now, the job of the senior person in a public antenatal clinic, certainly the way I used to look at it, was that if I'm going to be the only senior person to see this woman, then my job today is to spend plenty of time with her and make a detailed plan that the junior people can just follow from then on. Yeah. And so to help this lady make a detailed plan for safe care of her pregnancy, if blood's off the table, then we're going to make a plan with a senior experienced person. And then the other visits, the non-planning visits, just the is your blood pressure okay, is your baby growing visits, can be done by a junior person. And then we come back to the senior person to review the plan, make sure we're happy, and then institute that plan when we come in to have the baby.
Is it only postpartum hemorrhage that is the problem with blood products? Because she said that she wants a plan for all possible scenarios, whether it's vaginal birth, assisted birth, cesarean.
But the problem is going to be postpartum hemorrhage.
Yeah, that's the only problem that you need a blood transfusion for.
Oh, pretty much.
Yep.
Yeah. So it's rare at a Caesar you would never bleed so much at a Caesar from just you cut the uterus and it bleeds. That's not transfusion type bleeding. The transfusion type bleeding is when you cut the uterus, it bleeds a little bit, but you put some stitches through that like you normally would, close it up, and it still won't stop bleeding. Okay, so that's postpartum hemorrhage. Same with a vaginal birth. Some postpartum hemorrhages are caused by tears in the vagina, but they are relatively straightforward usually to put some big stitches through and the bleeding stops. The big ones that we worry about are what's called atonic bleeds, where the uterus is big and floppy and can't be contracted, and we give a bunch of drugs and it still won't behave itself. And we do this and we do that. And if I didn't have access to my bottom rung, to my sort of, okay, we're in trouble here, we're going to have to give some blood. If that was off the table, then I would be doing everything at the top of the page. Sooner, more aggressively, more preventatively, so that I never had to get to the bottom of the page.
She mentions the care for the baby upon delivery, like delayed cord clamping and vitamin K injection. Is a vitamin K injection, is that a blood product?
No, it's not a blood product. So vitamin K injections are to prevent a rare but serious complication of newborns where their blood clotting system isn't working terribly well and they can have severe or life-threatening bleeding. And the problem with that is we never know which baby's going to have that. Yeah. So it's a bit like vaccination. You have to treat tons of people to save a few. And so because we don't know who's going to get it, we like to give every baby a shot of vitamin K. That fixes the problem. And then the small number that were going to have the problem are fixed, and all the babies that weren't going to have the problem, vitamin K doesn't harm them. That's not a blood product, and I would recommend that to this patient.
This is a good plan for her to do a vitamin K injection.
Yes, but I would recommend that to everybody. Yeah. What was the other?
Oh, delayed cord clamping.
Oh, yeah. So a plan should be made for delayed cord clamping because there's a scenario in which you might want to not use delayed cord clamping, because what you really want to do is clamp the cord, get the placenta out, and get that uterus contracted as soon as possible. Yeah, if the woman was bleeding.
Yeah, right.
Right. So I'd have a flexible plan in place here, where I said if your baby comes out and there's no bleeding at all, then fine. Let's bat on with a delayed cord clamp, and it's only a couple of minutes. Let all the blood drain out of the placenta down into the baby. But if you are already bleeding heavily, then that 2 minutes of waiting for the blood to go into the baby could be highly significant in your overall losses. And considering we can't give you blood, I would encourage this woman to work on a plan where she said, rightio, if we can't use blood, let's never get into the situation where we need blood. And perhaps that might mean cutting the delayed cord clamp short, because what we really want to do is get the placenta out, get the uterus contracted and stop the bleeding in the first place. Yeah,
great. These are all good suggestions. I hope that this helps you in your chat to wherever you're having your baby, and just have a plan and know that plan exists in your file.
Planning. So hospitals have got proper formal paperwork for this.
Well, that's good to know.
Yeah, so there's a document and it clearly says, I'll accept this, but I won't accept this, this, and this. And it requires the whole situation to have been overseen by a senior person.
Great. Well, everyone, that's us for the week. Thank you so much for listening. You might have seen that we read out some from our Grow My Baby participants. That's the way you get up the speak pipe. More than welcome to join us in that program, and the link is in the show notes, or otherwise it's on our website, which is growmybaby.com.au. All right, thank you for listening. We hope that you have a really fabulous week, and we'll be in your ears next week.
It's been fun. Thanks for listening, everybody.
All right, bye for now. I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
this person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.